everybody. My name's Elizabeth Goacher. I'm a physician assistant and I'm at Duke University Medical Center. And I'm really excited to be here as part of the MASLD Community Network that we're putting together. We hope that you'll enjoy all the different offerings that GAP has put out as part of this. And big thanks to our sponsor, Madrigal, who's backing us all to help spread the word and spread the love about how to take care of MASLD, how to identify it, how to treat it, how not to treat it, and how to help your patients generally. I am at Duke University Medical Center. I'm a physician assistant and I've been here for 24 years. Before I was in hepatology, I did primary care for several years. And I think it's really interesting to be in the MASLD space, really coming back to the beginning of where I started, right? Metabolic dysregulation is something we see in so many different entities that are especially focused in primary care. Obesity management, hyperlipidemia, diabetes, hypertension, cardiovascular disease, and now MASLD, we're adding to the spectrum, liver manifestation of metabolic derangement. I think it's really amazing that we're all circling back to our basic training. All of us, NPs and PAs, PharmDs as well, all of us that work in this allied health field space focused on those basic primary care, internal medicine basics. And with MASLD, we're just bringing it back home. So with that, my podcast today is going to be talking about the disparities that we see in MASLD. We know that healthcare disparities are things that we talk about in lots of different phrases and lots of different frameworks. Some of the disparities that get addressed are about race or ethnicity, socioeconomic status, lack of access, inequality. In general, we're looking at what is it that is unequal in different components of MASLD when we think about healthcare disparities. The disparities for MASLD are no different from the general population overall. There's a little more focus that we've noticed that aligns with the burden of illness in the Hispanic population, where we see a greater, compared to non-whites, we see a higher obesity, we see higher rates of diabetes. So it follows that we see higher rates of MASLD in that population. And we all know that people who have a lower, it's been demonstrated several times over that lower socioeconomic status, food islands, food deserts are additive to MASLD stress. And it has to do with a lot of times with the lack of food, the lack of nutritious food, and the increased focus on polyunsaturated fats and higher fatty content foods, and the higher calorie dense things that are more fructose corn syrup based. So depending on where you get your groceries, we know that's going to create a disparity. Multiple studies have demonstrated that your geography and your zip code have significant connections to your risk for things that are part of the metabolic syndrome. Higher rates of cardiovascular disease, higher rates of diabetes, higher rates of cholesterol problems, higher rates of MASLD and obesity. We know that in particular with MASLD, the research within MASLD itself, that men more than women are affected by MASLD. We know that, as we all just mentioned, that Hispanics have the greater rates than non-Hispanics and then also than Black people. So it's a spectrum, more whites than Blacks, more Hispanics than whites. So we have a spectrum of disparity of prevalence there. And we know that also it's about things that are outside your control. One of the things that's really tough, I think, when we think about healthcare disparities and access disparities and the inequity and inequality that exists in healthcare for our patients, it has to do with things that are outside our immediate control. We may have ways to start impacting them at the systemic level or at the wider scale. But for you and me every day in our clinic, what can we do to mitigate bias? What can we do to impact the disparity that we know exists? We may not be able to fix the disparity, but what can we do within our power, knowing that it does exist with that patient that's in your room? And I would say that the main thing that we need to do is focus on that power. What happens in my exam room is a dynamic between me and my patient and my staff and around us. And making an impact there to mitigate bias is one place that we can bite off and chew. We need to treat all patients the same. When we're talking about how do we address factors that help MASLD and what we need to do in both diagnosis, screening, diagnosis, management. Don't make assumptions about that person in your room. We want to treat everybody the same. What do they have, and ask them what access they have. Don't make assumptions what they do or don't. It's fair to assume that people will tell you if you ask them what they need. If what they have access to is what you can work with, at least you're starting there. Doesn't fix the bigger problem, but bite off what you can do and control what you can. So I don't want to sound like it's like, pie in the sky. I don't want to be Pollyanna, but what can we do that we can make a difference in? And those are things that we have control over. Making no assumptions about what that patient's diet was like. Making no assumption of what that person's exercise habits are like. No matter what their weight, no matter what they look like on the outside, knowing that all people are individuals, we can mitigate that disparity, that perceived bias, that tendency to lump people into categories. Oh, you have this cultural background. This is the diet you eat. oh, you are this body size. That's probably what you do or don't do for activity. Trying to let go of those is how we can make a difference in our exam room, and asking the same questions of every patient. Now, it's important to acknowledge that cultural backgrounds and ethnicities do inform some of our mores and some of our cultural patterns. But to assume that everybody has the same diet or the same exercise habit or the same muscle build, we got to get away from that. Got to do what we can to make the impact where we can. So that also means that when we're making our recommendations for change, we're addressing the disparity in access. We're looking at, what do you have access to? If you can do XYZ, do you have, do you have sidewalks in your neighborhood? Great. Are they safe to walk on? Great. But starting at that same point, don't assume they don't have sidewalks. Don't assume they do, right? Based upon their zip code, and making sure that we're asking our questions of the same person. Do you feel safe exercising? Does it in your environment? Do you feel safe from your personal status? Like you can stand up and not fall down, your balance, those kind of basic questions, starting there and going from there. We can make a difference and that impact this if we ask the right questions and get us moving in the right direction. And I think that if we feel like we're failing in addressing disparities, because, it is a big picture. It is more than just us. Think about the fact that the prevalence of diabetes, the prevalence of MASLD in diabetes is potentially 70%. The presence of MASLD in people who have a BMI over 30 is up to 90%. Estimates range 50 to 90%. The prevalence of MASLD in people who have atherosclerotic or cardiovascular disease is 70%. The prevalence of MASLD in people who have hypertension is 50%. So if we are looking at the disparities that we're addressing, if we are addressing MASLD, no matter where the higher prevalence of diabetes is, no matter where the likelihood is that this person has a greater chance of being overweight just based on statistics, if we're all focusing on diet, exercise, and MASLD screening and trying to treat that, we're going to make a difference in all the different comorbidities they have. And in that sense, we are trying to move the needle toward equality. We're trying to treat people all basically like they have risk for MASLD. If we all assess that they're at that same risk for MASLD, if we're all looking at this at one way, we're trying to start with that individual patient and go from there. We're going to be addressing that disparity. I hope that makes sense. It's the thing that I hold on to every day in my practice when I feel frustrated by what I see outside my exam room, but at least I control what's inside my exam room. And I take reassurance that in trying to address these particular pieces, I am doing the best I can do. And that looking for disparities and trying to address them in even more detail starts with then something about who you get into your exam room and what you can do to get them there. And so targeting screening programs where there's a higher prevalence, which would be in diabetics, which would be in people who are overweight, which would be in cardiovascular disease and hypertension, but also by socioeconomic patterns and trying to address that as our next step. So that's all I have for now in my meanderings and wanderings about addressing healthcare disparities that APPs encounter when it comes to MASLD. I hope that you found it helpful. I would love to join the conversation other times. We hope that you'll log into some of the other parts of both my website here, but also all the other websites that are available to use through the GAP. MASLD MASH Alliance to get your voice heard. We want to hear from you. So make sure you're sending in comments. Make sure you're trying to log in and be a part of the conversation wherever you can. And we really want to thank Madrigal for supporting this effort. That's all I have for now. Thanks a lot.